Hello, and welcome back to Decoding NF. My guest today is Dr. Tessa Hadlock. Dr. Hadlock is a distinguished facial plastic surgeon and a leading expert in facial nerve disorders, known for her pioneering work in treating facial paralysis. With nearly 3 decades of specialized experience, she has developed cutting-edge surgical techniques that have set new standards in the field. Dr. Hadlock is a professor at Harvard Medical School and previously served as the director of the Facial Nerve Center at Massachusetts Eye and Ear, before founding her private practice, the Hadlock Center for Facial Plastic Surgery in Boston. Her contributions to medical research are internationally recognized, and she remains deeply committed to mentoring the next generation of surgeons. Fluent in several languages, Dr. Hadlock combines clinical excellence with a compassionate approach to patient care. This was a surprising and super fascinating discussion about a topic that I was completely unaware of until I learned about it from my conversation with John Manth. When he mentioned the idea of facial reanimation, it was a concept that blew my mind, and I immediately knew I wanted to get Dr. Hadlock on the show to fully explore it. And fully explore it we do. I think this episode serves as a great primer on facial reanimation treatments and strategies, both in how it relates to NF patients, mostly NF2 related schwannomatosis, but also in general. We covered the major invasive and non-invasive intervention options for facial paralysis, both from a functional but also a cosmetic standpoint, and importantly, we talk about risks and outcomes quite a bit, which I think is really important. In NF treatment, we're often choosing between difficult options with uncertain outcomes. But this is an area where the relative risk to benefit ratio can be really high in terms of quality of life, and Dr. Hadlock has spent her entire career trying to track and quantify the results of the intervention she engages in. So I thought it was a good opportunity to explore that aspect in a way that we don't always get to. As always, the content of this podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and listeners should not disregard or delay in obtaining medical advice from their doctors. One last thing, Decoding NF has a Patreon. For just $4 a month, you can support the show, and you get episodes like this one as soon as they are done being edited, which is usually a week to 2 weeks before they go live on this podcast feed. So please consider joining. You can find more details at patreon.com/decodingnf, or just go to decodingnf.com. And there's a link there right in the top navigation for the Patreon. And of course, in the show notes, if you're listening to this on a podcast app, there's a link to the Patreon in there as well. Without further ado, I hope you enjoy my conversation with Dr. Tessa Hadlock. Dr. Hadlock, thank you for joining me. So I just want to start with a little bit of your background and how you ended up in facial paralysis surgery specifically.
So I was always really interested in surgery because I grew up in a very kind of a manual household. And when I started to focus on surgery, I recognized that the area I loved the most was the head and neck. And then once I got into head and neck surgery or otolaryngology, the thing that drew me in so much was facial surgery. And I think the problem with facial paralysis was absolutely alluring because not only does it involve facial aesthetics, but also facial function, human function, and nonverbal communication. So it had this trifecta of issues that really attracted me. I feel like that is the real reason why I wound up spending my entire career on facial paralysis.
I want to drill down into facial paralysis and NF2 specifically, but before we do, I think I wanted to just, I don't think I talked to a lot of NF2 patients as well, and I don't think most people really are aware that something like facial reanimation is even possible. And I wonder what your thoughts are in terms of why this kind of surgery isn't I don't know, more well known. It seems like a lot of NF2 patients, they may have a nerve issue or something, and they don't even realize this is an option.
Yeah, I absolutely appreciate that comment. I think that there are so many diseases that result in facial paralysis, and NF2 is one of those dominant diseases that can result in facial paralysis on one or both sides. And the problem is that people, both patients and doctors, get so focused on the disease itself and the natural history and managing advancing disease that they forget sometimes that quality of life is the fundamental pillar upon which a lot of our therapies should be based. And so they overlook that there are a lot of short climbs for a long slide where we can give people a really significant benefit with surgery that, or not even surgery, sometimes minor interventions that can really improve the way that they express themselves on the face. It's just overlooked. It falls in the shadow of the more dominant medical issues in the disease process.
Yeah, I was talking about this. We did an episode about pain and NF, and this really echoes that, which is that there has been so much focus on just trying to resolve the pathological kind of nature of NF1, NF2, et cetera. Because we've been losing for so long in that respect, there's been so few therapies that actually treat it, that the actual quality of life question really does take a back seat, both in mental health and in stuff like this. I think this is a really interesting and, to me, unexpected pathway to that quality of life question. So when John Manth referred me over to you to talk about this, because he mentioned, oh yeah, we did this facial reanimation surgery. I was really like blown away by the concept. It just had not occurred to me. And partially that is because of my experience. I've never, had to deal with anything that involves facial paralysis, and so I just wouldn't be exposed to it. But also, I'm in the NF community. I just had not come across it conceptually. So I was really interested to explore this further. Let's talk a little bit about NF2. And when you have an NF2 patient that comes to you with some kind of facial paralysis, nerve damage in the face, what's usually driving that for NF2 patients?
Yeah, absolutely. One other point I really want to make before I answer this question is that when you ask why it's not at the forefront, why facial paralysis management isn't at the forefront, another thought that came to me as you were just speaking is that oftentimes patients are led toward different avenues to pursue therapy if their physicians or their physician team brings them to the realization that there are things that can be done about these things. And I actually think that in NF2 patients, their primary points of contact are their neuro-oncologist or their neurosurgeon. And the problem is that sometimes that group isn't as aware of all the different things that can be done, or their experience has been that a lot of those surgical therapies haven't been that successful, so they don't want to push those. So that was just to add to your prior thought about sort of why there's a hole in there that I would love to fill, and I think we as a facial reanimation community want to fill over time. But getting to the question that you just asked in terms of NF2 and how and why it results in facial paralysis, there are so many different reasons why an NF2 patient might develop facial paralysis. The most common thing is having surgical therapy or radiation therapy for an existing vestibular schwannoma. That's like the number one condition that results in usually transient facial paralysis. But there are a number of other situations in which an NF2 patient gets facial paralysis. For example, an actual primary facial nerve tumor related to the disease process. So I've had patients where there was a middle ear mass and a surgeon went after that mass, and ultimately it proved to be an NF2 related tumor that then sacrificed the facial nerve because it wasn't recognized that was the facial nerve mass.
Now, is it always neurological in nature, or is there sometimes a vascular source to kind of facial paralysis or other things in the face like that?
It's almost always a neural source. So the facial nerve either gets damaged because it's collateral damage to neural surgery that's adjacent to the facial nerve, or it's damage to the facial nerve, or iatrogenic or intentional sacrifice of the facial nerve for an enlarging tumor within the facial nerve. However, in NF1 and other conditions, sometimes there are massive facial tumors that directly involve the facial musculature. And when that happens, it's not really a neural problem, but rather the end target muscle that either needs to be resected or gets directly invaded by tumor.
That's interesting. I was thinking of this as an NF2 kind of problem primarily, but I didn't really even consider the fact that, yeah, it can affect NF1 patients as well. Maybe a smaller subset, I would imagine, though.
Absolutely. A smaller subset, but it's definitely real in NF1 occasions. And I think talking about facial reanimation is relevant to that community as well, though not as relevant as in NF2 patients.
So I want to dive into treatment options then for a patient with facial paralysis due to NF2. Is there anything that characterizes facial paralysis with NF patients in particular? Is there anything unique about the pathology that they experience, or is it all mostly of a kind?
There are a couple of unique aspects of facial paralysis in the NF2 population. The first two that really come to mind are, number one, patients tend to be younger when they experience facial paralysis. And that is a good thing for facial reanimation. So a young patient or a middle-aged patient with NF2, I tend to think of them as a very healthy crowd compared with patients with other conditions that result in facial paralysis. For example, head and neck cancer patients who often don't have the same fundamentally healthy substrate. So they tend to be patients in whom facial reanimation is actually slightly more successful than in other populations. They don't tend to have the vascular disease that we see with smoking and other lifestyle changes that can give unhealthy donor vessels to free flaps, which is one surgical option for facial paralysis. So in general, I would say that facial paralysis associated with NF2 hits a bit younger and that we have better results with facial reanimation because of that. But the other thing specific to NF2 is that both facial nerves are essentially chronically at risk for facial paralysis. So in unilateral facial paralysis that is based on an isolated brain tumor, an isolated stroke, a head and neck cancer, or a benign parotid lesion, or something that's only going to happen on one side of the face and would be extraordinarily unlikely to happen on the other side, we depend on the contralateral facial nerve for a lot of our facial reanimation options. In NF2 patients, we tend not to do that as much because we don't want to basically hang our hat on normal contralateral facial function for the rest of that patient's life. So we tend to use more alternative neural sources for facial reanimation, if that makes sense.
Yeah, so let's talk about that then. There's essentially 4 options for facial reanimation surgery, right? If I'm understanding correctly. Could we step through each of the modalities of treatment, and then we can dive into each one in a little bit more specifics? But let's just do an overview of what are the options if somebody's having facial paralysis for treatment.
Perfect. This is my favorite subject. So there are really 2 flavors of facial paralysis that NF2 patients can experience. There is flaccid facial paralysis, in which there's been a sacrifice of the facial nerve or very significant damage in the skull base region where they are not likely to experience recovery. In the flaccid face, the options are threefold. There's static facial reanimation, in which we take fascia or tendon material from other parts of the body, and we basically just provide some ribbons underneath the skin that secure the corner of the mouth in the appropriate spot, the crease between the nose and mouth in the appropriate spot. We stabilize the central face so that when people smile, things don't shoot over to the healthy side. And that static intervention improves speech, articulation, oral competence, keeping liquids and solids inside the mouth. It opens the nasal airway. It does a lot of good things. but it's not the sexiest thing that we can do because it doesn't offer movement. If we want to really introduce movement, there are two main surgical options. The first, which occurs when we can get to patients within 6, 12, 18 months of their paralysis, is to provide alternative axons to the distal facial musculature. And usually we will steal one of our 8 huge chewing nerves, which are innervated by the trigeminal nerve, very unlikely to be involved with NF2. And we basically cut one of those chewing nerves and we sew it into a relevant distal facial nerve branch so that it brings back, let's say, smiling with, at first, patients do a little small bite. And then after a while, patients can learn to use that without even clenching their teeth closed, and they can get a beautiful smile. So those are called reinnervation techniques, stealing a different nerve to plug it into the distal facial nerve branches and actually wake up the facial muscles.
So real quick, before we go on, I want to take a step back there from a lay perspective and step through those two options just to make sure I'm understanding their implications. So in the first option, what you're really doing is you're just creating tension under the skin with a tendon or some other kind of I guess you could say, inert tissue that essentially pulls on the musculature of the face in a certain way that allows for symmetry to occur, because those muscles that would normally be creating that tension are completely inactive. And then in the second option, you're actually grafting a nerve from a nerve that supplies a different set of muscles in the face. And so the implication in that case, if I'm understanding correctly, is that actually they would need to, like you were saying, a small bite or something, they would need to learn, their brain needs to learn a different set of actions to activate that muscle. Is that right?
That is 100% correct. And you can think of it as robbing Peter to pay Paul. So I have to denervate one of the chewing muscles to provide juice, if you will, to some of the smiling muscles or some of the periocular muscles. But we only rob people of muscles that we know can be easily made up for by other healthy muscles. So in the end, people do not wind up with new deficits in order to restore facial movement.
That is a question I have, because if you're making a small kind of change to one set of muscles for the purposes of, or I guess the nerve supply of a particular muscle to affect a different one, what are the knock-on effects of that, even if they're small? Do patients have differences in the way that they chew, or differences in their kind of mandibular power when they're eating something? Like, what do they need to be conscientious of after a treatment like that?
Great question. So there are two things. When we use the masseteric branch of the trigeminal nerve, which is really one of the most common nerves that we use, people can experience two things they have to be aware of and that they might need a little therapy for. One is that because we're taking away part of the innervation of the masseter muscle, they can get a little temporomandibular joint syndrome, a little TMJ. So when they bite, they can have a little bit of discomfort. But luckily, there are a lot of therapies for TMJ, just in terms of warm compresses and sometimes over-the-counter analgesics and things like that, and a little bit of changing in the diet so that we're not doing crusty, hard breads and stuff like that, that can manage the potential TMJ. The second thing that can happen, and I see it a little bit more in wider lower faces or an Asian kind of a face where there's a wider bulk in the masseter regions, is that when we take the nerve, it can almost look a little bit hollow where the masseter muscle gets a little bit atrophied. In those cases, we can camouflage that atrophy pretty easily with a little bit of filler therapy or even a little dermal graft, which is where we take a little piece of not skin, but what's right under the skin from, let's say, the lower belly or some inconspicuous spot. And we make a little nick under the skin and we drape in a little bit of extra tissue so that we can camouflage that volume deficit.
That's super interesting. Okay, sorry. So I interrupted you. You were stepping through these first two options, and you mentioned there were some other therapies. Now, these two therapies are related to if the muscle in the two we just talked about are if the muscle in the face is completely flaccid, so they've completely lost function.
And there's no real expectation for recovery. The third option in that clinical scenario is to do free muscle transfer. Free muscle transfer means that we take a muscle from elsewhere in the body and we transplant it into the face. And there are a number of muscles that replace the smile musculature or the periocular musculature. But the most common one that we use is the gracilis muscle from the inner thigh. The reason we love that muscle is because the scar is relatively inconspicuous in the inner thigh, way up, so that even like a pair of shorts would normally cover that incision. And so that therapy is appropriate for people who have flaccid facial paralysis for a prolonged period, let's say more than 18 months. In that scenario, you can provide axons all you want, but it would be very unlikely that the native facial muscles would wake up when you provided additional neural inputs. That's not necessarily true in very young children and even in young teens. But as we get older, by the age of 15 or 18, after 18 months of deprivation of neural input, we need to use a fresh piece of muscle from somewhere else in the body and transplant it into the face. That's called free gracilis transfer. And we usually do that to restore the smile, though we occasionally are using it to also help people pull down their lower lip in a pleasing way when they want to expose full teeth for a big open mouth smile. And there are also some descriptions of providing the gracilis muscle in the smile region and a slip underneath the eyelid so that when we smile, we get a little bit of elevation of the lower eyelid that helps us protect our eye.
And then outside of that, there are sometimes temporary treatments like Botox that are appropriate for NF2 patients. Could you talk a little bit about when that might be appropriate and
Yes,
what the implications of that might be?
absolutely. So we just talked about therapy in the flaccid face, which is one unfortunate sequela of NF2 related management of vestibular schwannomas or facial schwannomas. But more commonly, or at least as commonly in NF2, when the surgeons remove a skull-based tumor, they transiently stun or damage the facial nerve, and a lot of recovery does then occur. Those patients are not flaccid, but rather they can be hyperkinetic, almost where they recover, but there's no good off button for that recovery. So sometimes they wind up a little bit too tight in the face. So their facial muscles are innervated by facial nerve fibers, but they're a little disorganized. So a fiber that used to go to the smile might now go to the eye muscle, or a fiber that used to go down into the neck goes up into the forehead. And so those patients need really an entirely different set of interventions to help them organize their facial function. And among the tools that we have to manage that are Botox, which, for those of you who don't know, basically temporarily disconnects a nerve from a muscle to calm it down. It just does that pharmacologically. It doesn't do it anatomically. So it wears off and it goes right back to what we used to have. But it basically can help inappropriate activities disappear temporarily to improve function. Physical therapy is an extraordinary tool for that kind of hypertonic or synkinetic face, where a highly trained, specialized physical therapist can help a person to reprogram with neuroplasticity their cortex to better control movements in a voluntary sense when they want to make certain expressions. So physical therapy, botulinum toxin, which is really a medical therapy. And then there are also some minor surgical maneuvers that sometimes, let's say, snip away a revved up facial muscle that you never really want to activate in the first place, like there's a little frowning muscle at the corner of the mouth that we almost invariably want to throw in the trash can because it hinders smiling a lot after transient insults to the facial nerve with aberrant recovery. And nobody ever misses it when they can't make a huge downturn frown.
Okay, so if I'm understanding correctly, so we're talking about after surgery or after some kind of resection that affects a facial nerve, that nerve will sometimes grow back And as it grows back, it might branch out and connect to the wrong muscle or a different musculature than it was previously connected to or should be connected to. And that can cause an activation of a muscle that's unexpected when a certain facial movement is done. And you said something interesting that I didn't realize was possible. So PT can actually be useful in this case to cause somebody to unlearn a particular facial muscle activation. Could you talk a little bit more about how that works? If you're like, PT is just not an area that I know a ton about, that's also fine. But that's something that's really interesting to me because I think of, and I think probably most people think of most of our facial movements as intentional, but involuntary in a sense, right? Like we do a lot of movements in our face, but we don't really think about which muscles we're specifically activating. And I wonder how that process works.
Mhm. I'll preface this by saying that there are just a handful of physical therapists in the country, or maybe the list is even shorter than that, who really can talk about the very specific things that physical therapy does more at a physiologic level. But I want to not correct you, but add to what you're saying. Facial expressions happen in two ways. There are voluntary expressions, a social smile. Hi, it's nice to meet you. And you smile intentionally. You want to close your eyes because you want to think hard about something or keep the sunlight out. Those are voluntary movements that we do. There are also involuntary emotive expressions that when somebody says something funny and we laugh out loud, we can't control those. So there's a set of expressions that we do control and a set that we don't. And the pathway is totally different, where the voluntary expressions come from the motor cortex in the cerebrum. The involuntary comes through the amygdala and all this kind of central core emotion pathways. When physical therapists work to try and do neuromuscular retraining, they are able to take advantage of the cortical plasticity. Basically, that's our brain's ability to reprogram certain voluntary motor areas in the brain. And it turns out that facial muscles, all the zones that control facial muscles are all in very close proximity to one another in the motor cortex. And so getting those to crosstalk by repeatedly trying to make an action and understanding what the action does, and then trying to reprogram the brain that way is relatively effective. I am not certain, and I think it would be interesting to have a physical therapist do a podcast. I think that it would be interesting to know whether the involuntary pathways could be affected in a similar way.
Yeah, I really would like to get some PT representation on the podcast. Not just for, I mean, the facial stuff is wild. I hadn't actually even considered that was an area of kind of specialization, but just in general related to NF, there's a ton of PT stuff related to NF1, NF2 that I just don't think I know a lot about, and I don't think that kind of the community at large. I think PT gets short shrift in general, in the same way that mental health has a tendency to take a back seat in these types of pathologies, and I really want to spend some time with that. So if you have any names that you want to throw my way that might be open, I would absolutely love to reach out and see if we can schedule somebody.
100%. I'd be happy to do that for you.
I have a couple questions about specifics of some of these procedures that I want to explore a little further. With the free muscle transfer, when you're moving muscle from the thigh into the face, how much muscle are we really talking about moving? You know, how much of material are we actually taking from the thigh? Does it affect the thigh muscle at all, really? Or is it such a small amount that it doesn't affect function? And also, how do you know how much to move to achieve the effect that you want to achieve in the face?
So some of those questions are known and some are not known. We do know that from just thousands and thousands of gracilis removals for all kinds of other reconstructions around the body, that there really is no significant morbidity to taking out that little slip of muscle in the medial thigh. we have really large other muscles that perform the same action. So the only time that we might hesitate, and even then only a little bit, would be like in a professional athlete who uses their muscles to an extraordinary degree. But other than that, the morbidity of removing this little slip of what we really call a vestige muscle from the thigh is minimal. The question as to how much to put in is a great one. When I was learning these techniques about 30 years ago, the thought was that we had to put in 25 to 40 grams of muscle in order to get movement. But ultimately, what people discovered was that was frequently resulting in bulk or visibility of that muscle in the face. And over time, we systematically tracked how little muscle we could put in and still get an appropriate excursion. Now, there's an element of unpredictability in all of these facial reanimation procedures. And so sometimes there is not a direct correlation with how much you put in and what kind of smile excursion you get out. And we've published an awful lot about which variables predict the outcome. And unfortunately, after 30 years of doing this, I'm really still, all I recognize is how much more there is to really study about that. But I will say that we have an upper limit of around 15 grams of muscle that we put in the face now. So that means that when we take the segment out of the leg, we have a sterile scale in the operating room and we weigh it and we assure ourselves that we don't provide more mass than that. Having said that, I have patients with only 6 grams of muscle in their face and a beautiful smile, and patients with 12 grams of muscle with less excursion and a little bulk. So there are clearly some variables that we haven't been able to put our finger on. Where we have made progress is, let's say we do this operation and somebody winds up with a smile they're pleased with, but the face is a little bit bulky. We've gotten very comfortable in correcting that bulk abnormality after the fact in these kind of minor touch-ups. So we no longer feel that we're going to put their whole reconstruction at risk if we want to fix that one thing. So there are many fewer things to fear about this surgery than there were, let's say, even a decade ago.
And that segues right into a little bit about outcomes and success rates. So for a procedure like this, and I know probably each procedure is going to have a different set of considerations and stuff, so feel free to go down all those roads, really. I really intend for these to be as comprehensive as possible, so don't feel like you're inundating with too much information. But with each of these procedures, what are the considerations and risks that need to be weighed? And then I want to talk outcomes as far as long-term outcomes, keeping in mind that disorders like NF2 come with their own variability, of course. But just in general, like if nothing changed, what are the long-term outcomes for these various procedures as well?
Yeah. Okay. So the first question is about risk. And in the NF2 population in particular, these patients are all facing intracranial disease, spinal disease, and soft tissue disease and nerves throughout the body. And they often face riskier surgery with craniotomy and pain syndromes and all the kinds of things that your podcast is probably intended to cover. So when it comes to facial reanimation, I like to think and I like to say to patients that anything that we do to a patient is so much less risky than all of the other things that these guys have to handle in the course of their care. And that is, I would say, that has borne out as a very honest statement over time. It's not, the things that we do not tend to be dangerous or have really significant morbidity. Has there been an occasional, I think I can think of one patient in my career that needed a blood transfusion after surgery, and a couple of people in whom there were some rocky postoperative courses, of course. But generally speaking, the risks are very low. The problem, the biggest risk with facial reanimation is that it can fail. And there are some patients who cannot accept that risk of failure, and that's okay. What that means is that they shouldn't have facial reanimation. So patients who come in, who hear the options and say, I'm willing to get on board with this project and roll these dice and get involved with Tessa to try and make this happen, that's a great candidate. But a person who's been through either very negative medical experiences or has a very significant aversion to the possibility something might not work is somebody that we have to really consider very carefully whether surgery is an option. And I have a lot of NF2 patients who, at the outset of my proposing these different things, need time to process. And then over time, they come to appreciate, or they just become more comfortable with the idea of the risk of failure. And ultimately, we proceed. So with free muscle transfer, at least, there's really no time frame. So we can take all the time that we need together as a partnering team to really get to a point where we know what the best decision for that individual patient is. In terms of long-term outcomes, I have spent my entire career trying to meticulously track every single facial reanimation procedure and its short, middle, and long-term outcome. It's a massive undertaking. I am pretty good at it, and I still basically stink at it. It's very hard to keep track of these outcomes, and particularly in the NF2 population, because often people with NF2 will travel to centers for their care. So they start off with a particular neuro-oncologist and they come back and that person follows them on a year-over-year basis. And so they might get facial reanimation with me because they're being treated, let's say, in the Boston area. And I don't have as good access to them when they go back to their home state to follow photographs and clinician graded outcomes measures and all of those things. But I will emphasize for you and for your listeners that keeping meticulous track of outcomes is the most important thing that we can do. And we owe it to the NF2 population, and we owe it to the facial nerve population in general. And no matter how many times I say that over the course of I'm in the senior years of my career, it's still very hard to try to get clinicians to do that, and patients. And it's not because they don't want to, it's because the climate in medicine makes it very difficult for people to take the time to track patient-reported outcomes, clinician-graded outcomes, layperson impressions of outcome, and objective outcomes. It's time-consuming, it's expensive, and we, as it is now, don't have enough time to spend with our patients.
Yeah, that makes sense. But I do wonder, just in terms of patients that you've had over the years, would you say that with most of these procedures, excluding, say, Botox injection or other temporary interventions, that these are permanent? Or is this a situation where, for instance, you do a nerve graft or you do a muscle transfer, and then in a few years, they may lose some of that function for one reason or another? Is it generally a permanent set of procedures, or is there a kind of infrequent need for other procedures down the road in your experience?
Yep, I understand exactly what you're asking. I would say in the case of static reconstruction, it is almost always successful. And what I mean by successful is they look a lot better at rest, maybe 70% better from an aesthetic and functional perspective, and it never really changes over time if you use the right materials to do that. There are some surgeons around the country who use artificial materials and Gore-Tex and things like that, and those do not tend to have the same longevity. But autologous materials like fascia lata from the thigh or palmaris longus tendon and those things, what you get is what you're always going to have. And the only way that really gets undone is if we have to cut it away to access the area for other surgery. When we talk about reinnervation procedures, also, once I would say that if we do that procedure within the appropriate time frame, it's successful far over 90% of the time. When I say successful, I mean that they get dynamic movement when they bite in the face. The spectrum of results can occur from exactly where those axons sprouted. So because when we're doing that, we can't stimulate the distal facial nerve branches because they're not awake. Sometimes we sew it to a branch that doesn't actually go exactly to the smile muscles, but maybe a little bit more vertically into the snarl area, or maybe a little bit too much into the eye or something like that. So it's very successful at innervating muscle, but it's not always successful at the right targets. And sometimes we need to do secondary surgery to take down, let's say they get a nice smile, but they close their eye too much as well. We can take down the branch that does that. Free muscle transfer in the NF2 patient, which is also driven by that chewing nerve, works 92% of the time. When I say work, when people bite, they get a smile. So that's the definition of success. There are things that can happen that then need secondary surgery to modify. For example, occasionally the muscle tightens a little bit too much and the corner of the mouth is a little bit too pulled at rest. That's something that can be undone a little bit and adjusted. Same thing with bulk. Same thing if we do it and the vector isn't exactly the vector that we want, we can alter those things. But as far as whether the operation works, 11 out of 12 times in my hands and in a lot of inexperienced hands, it's going to work. The trick is finding a very experienced surgeon in this because it's an unusual condition. A lot of people say they do facial reanimation and might have been trained in a center where that occurred, but the real learning happens in repeatedly doing the operations. And so you need to take the time to identify people whose volume then supports the results.
Yeah, it's funny that this comes up over and over again in my conversations, which is the need for experience in specialization, because almost all NF care in general is specialized in a lot of these areas. And I wonder if you see this in your field at all as well. When I talk to a lot of doctors, they say the issue is that there are experienced clinicians, experienced surgeons, experienced practitioners in general in their fields, and they're retiring, and people are not filling their place. There isn't a supply of other practitioners interested in those specialties and coming in as a freshman class to keep that tradition going. I'm wondering, in your field, are you having the same problem, a bit of a brain drain within this facial reanimation surgery, or is it something that people are really excited about and you find that there's a lot of people coming into it or a lot of interest in it in general?
Yes, I have the opposite problem to most NF clinicians, which is that I have a ton of people who are very interested, and I have a fellowship that people apply for and spend a year with me. And I would say there is almost too much interest in facial reanimation. When I say that, what I mean is that if there are too many facial reanimation specialists in the country, then no single individual is generating the volume that's going to make them excellent. But so far, in the past 8 or 9 years, I've trained about 22 fellows over my 22-year attending career. And I would say in the past 10 years, every graduate has gone back to a major academic center, 8 in the United States and 2 internationally. And I think that we are starting to stud the country with people who come out of training at a high volume center like mine and are capable of really becoming the next generation of experts. The problem is that there are also a lot of other people, even at those centers, who would like to do it because it's such a captivating and alluring problem. And that can tend to dilute the volume. And I am not a believer in diluted volume for highly specialized problems.
I guess the upshot is that unlike a lot of NF specialized care, a lot more patients probably have access to this than they think or that they might initially assume without having to, say, travel to Boston or something like that. But it's interesting that there is a balance to be struck between how many practitioners are in the field versus how many actual procedures that need to be done so that those practitioners can become skilled enough to have that level of expertise. And I imagine that impacts outcomes as well, how often a procedure has to be followed up with a secondary procedure. Because one thing I wanted to ask about that has come up a few times, there's a modicum of trial and error involved. This is just having done enough procedures to know when you're connecting a muscle in a particular way, as you're performing a graft or whatever, that you're going to achieve a certain outcome. How much of that is, okay, we're going to do this procedure and then we need to let it heal and we need to see what happens? And how much of that is technique that you can do during the procedure to understand what the impact's going to be? And how does that work?
Yeah, that's a really nuanced question. The way that I train other surgeons is in a very codified way. And I think that I have learned through mistakes the rights and wrongs of a lot of these techniques. And I am able to convey that information very easily to trainees as they come through. The problem is that there is also a next level of wisdom that comes from following outcomes and trying to connect what you did to what happens in the long run. And with facial reanimation, clinicians themselves, surgeons themselves are often very ignorant of their own outcomes because they take so long to evolve, and clinicians are moving themselves or patients don't follow up and they're never getting those data back. One thing I've tried to be extraordinarily meticulous about, since I have never moved in my career from Boston, is to never lose track of a patient, even to the point where I'm contacting patients who haven't come back so that I get the answer to my own question. What I would say is that there are things that there are insights I have generated that I am able to articulate and teach to other people so they don't have to do the same 20, 30 years to learn. But there are also things I think that simply come with age. And there was an article written about, I think it was a rhinoplasty surgeon or some other type of facial plastic surgeon. And a trainee was asking, like, how do you know what to do with the nose? And the guy said, the nose talks to me. And when I first read that as a young clinician, I didn't really get it. But as I've gotten older, I almost feel that same way, like the face talks to me. And there are these very subtle things that I'm doing that I'm not able to articulate maybe to the people who are around me, but that I think make the result better in the long run. I don't know if that answers your question, but
in any kind of skilled practice, there is an element there that I think I totally get what you're saying, which is that there's an element of instinct that is built over time that is subconscious, right? The brain is so incredible at that. As you learn a skill, there are things that become, it's almost like when you're first learning to drive a car, you're thinking about every component of driving the car and nothing is automatic and it's very difficult and too much information. And then as you learn, so much of that becomes motor memory. And that's where the training becomes important, because you can either commit bad habits to motor memory or bad technique to that motor memory, and you can become a bad driver that way. But you can also unlearn and relearn things. And that's just the way I think that learning any skill works, and mastery of skill over time, especially something as complicated and involved as surgery. I think most surgeons would probably say there is like an ineffable quality to what they do, in addition to all of the quantifiable tools that they use to make things replicable and all that kind of stuff that just comes from the repetition of that and seeing the outcome. And to your point, I think that can be that a lot of surgeons, they kind of cut and move. And so they're just moving on to the next procedure. And that's a really good point that you make. And I don't know how many practitioners we have that actually listen to this, really. I think the audience is mostly lay, but I would really like more of that audience, because I think that is something that's lost sometimes, which is the importance of understanding the long-term outcomes, not just the successful procedure and then the next successful procedure and then the next procedure, but also understanding what the impacts to that are, because sometimes it's not just a matter of successfully executing a surgical procedure and then seeing how the patient heals and then moving on. It's also the execution of that procedure with the consideration of the fact that that patient lives with that for the rest of their lives and what the impact might be. And there may be something you can do a little differently as you learn, as time goes on, that improves quality of life outcomes rather than just clinical outcomes, if that makes sense. And I think that because in plastic surgery, you have to consider those quality of life outcomes as well, because that's one of your clinical outcomes, right?
Yeah, and I would argue it's the most important one. I think that in plastic surgery, in facial plastic surgery, and in all kinds of other reconstructive arenas, we've come to appreciate that the most important thing is how the patient feels. And so that's really come higher up on our list. I will say that it is so difficult to track facial nerve outcomes, and it's one reason why our field has not accelerated to the same degree as, say, breast reconstruction or limb reconstruction or transgenders. There are so many other surgeries where the results are much more immediate. And we suffer without those data, and it holds us back. And I also think that because we don't have immediate access to those data, we sometimes may develop misconceptions that stick with us forever. And I'm reminded of a book that I have just read that I'm really enthralled with, this book called Think Again. I can't remember the author's name, but we could look it up. And the whole idea is that you need to approach everything so scientifically. Even if you're really well developed in your idea, you've got to be able to rethink and ask yourself, what if I did it a different way? And I would say that in my own career, I'm having a renaissance of asking some of the fundamental questions of, like, how can I move this lip that's a little bit too low that gives them drooling or oral incompetence? How can I move it up in a better way? I think our responsibility is always to deliver the best result that we can. And also, on top of that, to continue to innovate and accept the areas that aren't good enough or where we could improve, and try to apply our wisdom to those areas.
Yeah, absolutely. The book you're talking about is by Adam Grant, I think. And I think it's a pendulum swing in society at large, but also in medicine, where there is this pendulum in medicine for increasing specialization that just drills down. And then that creates silos, and it creates kind of isolation between these specialties a little bit. And then it's, okay, now we need coordinated care to coordinate all these specialties. But sometimes what really just needs to happen is that people need to talk a lot more, and they need to communicate, and those data need to permeate those barriers between silos so that connections can be made between different specialists and different practitioners as well. People have a tendency to get into our own little bubbles, just culturally, but also in specialty fields, people get into their own little professional bubbles as well. And it's a good reminder that that's what symposia and all these mechanisms that are built to spread information and create those connections are all about. And it just shows how really important they are. A lot of practitioners are so busy, and they see things like conferences and symposia and stuff as a luxury that they would love to have time for, but a lot of times they just don't, or even just reading all the journals that they'd want to read or going through. And I think that we're coming to a point where we're realizing collectively that stuff is equally as important sometimes as the other continuous training that you might do. Just exposing yourself to other ideas, other practitioners, other people in your field and outside of your field, even making connections between those types of things.
I could not agree with you more. And sometimes I'm filled with sort of a sadness about the way that clinical medicine has devolved into this frenzy of hyper specialized care. And even when I was a trainee, this is 30 years ago, we spent so much more time just sitting around a desk, really thinking it through in a group setting. And the power of group thinking was much easier to apply. I think that academic centers are tasked with providing innovative care, yet with all of the other pressures and responsibilities and kind of promotional expectations and service expectations and even paperwork and reimbursement. I think that the entire system is actually causing us to move away from the systems that would really allow the breakthroughs. And it's one reason why I recently stepped away from mainstream academia into a solo practice, so I could actually hit the brakes on some of that and almost buy the luxury of more thinking time.
Yeah, that's a really interesting perspective. There's always a tension between creating systems that improve efficiency, things like the NF consortium, stuff like that, where it consolidates research so that we're not doing the same research over and over again, and spreading that information, because there's a certain inefficiency with everybody kind of doing their own thing and whatnot, and how people communicate becomes very sporadic and random. So consolidating that stuff has its value, but that pendulum can definitely swing in the wrong direction, and it can get too far down that road, and we can lose some of the spontaneous value that comes from just thinking about something for a while, or having the breathing room to talk through something with another colleague or whatever. All those little things. Sometimes that slack in the system is also really important. And I think we kind of rubber band back and forth between realizing how important it is, and then thinking, oh no, now we've built too much slack into the system. We need to organize better and we need to like streamline everything. And it's just like we go back and forth between that. But I hope we could kind of strike a better balance that allows to maximize both the benefits of organizational efficiency while also benefits of leaving that room, leaving that headroom, and hopefully taking some of the administrative burden off, because you're right, that is the biggest thing. You talk to researchers and 70% of their job is administrative at Harvard or whatever. When they get granted, they spend half of that grant money just in paperwork and making sure that all the right people are looped into things.
Like I had an experience where, or this happened frequently in the senior years of my research projects. I would get a new idea and I would say to myself, Tessa, get that idea out of your head. You don't have time for that idea. And that's not what we want creative people to be doing. I was like, Tessa, how dare you indulge yourself in a new idea? You've got to get back into the grind. And so that's I think when somebody is at that point, you have to pump the brakes and say, something's got to change.
Yeah, absolutely. You said creative, and I think that is also just one last note, and then we can start to wrap up here because we're at time, and I don't want to take up too much of your time. I know you're super busy, but you called yourself you said creative people. I don't know how many medical practitioners and surgeons think of themselves as creative, think of it as a creative endeavor, but there really is a massive component of it that requires the same level of creative thinking process that a lot of other creative fields require. And I think if we thought of surgeons and some other medical practitioners as being in a creative field, that might actually change the way that we approach some of those things. And we might change the way that we value some of those not strictly analytical modes of thinking in medicine, because I think that is really important, a really important component, especially when you're dealing with evolving disorders that are really complicated, that have a lot of different effects that aren't necessarily related to the core disease, like an NF. You have to be able to think creatively to be able to make those types of connections between, and I think that does require creativity that I don't know how many doctors think of themselves as possessing or as needing in their field.
Yeah, I hear that. I think that in facial plastic surgery and other plastic surgery fields, I would say that it draws in the creative people because they first think of a lot of what we do as like artistry. And so there are a number of people who are sculptors and who are painters and come from the artistic. So they're creative in that certain sort of three-dimensional way. And I think that, to your point, many doctors and certainly many surgeons can be very good if they're not creative. But I don't think they can be extraordinary unless they allow and develop that piece of their brain. They might be great followers of technique, but they are not going to change the face of care. And that's really how I've wanted to think of my own career.
It's that extra 10% that they just may never quite get to without that extra dimension. Great. I really appreciate you taking the time. I don't want to take up any more of it, but just in case there's anything we didn't mention here that you'd like to cover or anything that you want to point listeners to before we close out.
I think I would just end with the final comment that patients really do need to be their own advocates. And it's often hard to say to your neuro-oncologist or somebody that you're reviewing scans with, who's so delighted with your status or your lack of change in volume of your tumors or tumor burden or your nice response to drug X or drug Y, you need to still find the voice to say, I am not expressing myself adequately on the face. And I think that it's the onus is on the patients to have the courage to try and identify resources for facial paralysis. They're there. I'm here. Even if people aren't traveling to Boston, we can help them navigate their own local systems a lot better. I would like to see people get good facial nerve care. And however we in the facial nerve community can play a better role in that, we're here to do that.
Yeah, that's a good point to end on. And it's one that we often end on these conversations, which is how important it is for NF patients to be advocates for themselves. And you don't know what you don't know. So hopefully this interview clues a couple of people that weren't thinking about facial reanimation surgery as an option before they learn that it's something that's available to them, and they can start to advocate for it, because just like any person, doctors also can't know everything. Sometimes you just expect them to be the experts that know everything, but the reality is sometimes bringing an option to the table that they hadn't considered can be really important as a patient as well. So thank you so much for taking the time. It's been a really great conversation. And if there's any, outside of your website, if there's any other links, social links or anything like that that you'd like me to put in there, shoot them over and I'll be happy to do that.
Sounds totally awesome.
Well, that's it for this episode. Thank you to Dr. Tessa Hadlock for lending her time and expertise, and special thanks to her staff for helping to sort out some technical issues while we were getting set up for the interview. You can find all the show notes, links, and whatnot for this episode on decodingnf.com. You can find and interact with Decoding NF on most social media. Maybe leave a review on Apple Podcasts. I hear it helps somehow. And if you want to talk to me, I am easy to reach. Just shoot an email over to shane@decodingnf.com. And don't forget, patreon.com/decodingnf. It's just $4 a month, and you support the future of Decoding NF. Thanks for listening, and goodbye for now.